All right, so let's do a little talk about Achilles tendonitis. So I was talking with Cole. Cole is going through the Knees Over Toes program. He's almost certified, has some questions about some clients that he's seeing at the gym. So he's got one client that's got a chronic Achilles tendonitis problem, has a big bump on his Achilles, was told a long time ago that he probably tore his Achilles, and now he's about how old?
67.
67. All right, so chronic Achilles tendonitis, point tender, pain with dorsiflexion, so limited progress with knees over toes, with squats and lunges. So I was talking with Cole. Here is the problem that he's having. So A, this person most likely sounds like they tore their Achilles, partial tear. B, never figured out why they tore their Achilles. So if you are a physical therapist, you should be figuring out why people got hurt in the first place. You should never just be treating Achilles tendonitis or an Achilles tear. You should be breaking that down to figure out what caused the Achilles to be overloaded in the first place, which in turn caused the Achilles to tear. Your Achilles just doesn't wake up one day and say, boom, I'm gonna tear. There has to be something that's dysfunctional within the kinetic matrix that overloads the Achilles that causes the tear. So the problem that caused the tear was not the Achilles. It was somebody else who should have been either controlling eccentric pronation, or if he's exploding to go up, concentric plantar flexion or supination. So if you don't figure that out, how are you ever going to solve your patient's problem? Okay, let's say you saw him when he had his acute injury. You could get it to calm down, you can get the swelling to go away, you can get the pain to go away, you can force passive range of motion, get him to walk a little bit better, work on strength, all of that stuff, but the underlying problem still persists, which means he's going to have continued problems going down the line. So I want to break this patient down and what the thought process should be as you are evaluating them so you can figure out what the root cause of the problem was. Because if you are calling yourself a doctor and you have 7 years of clinical or 7 years of schooling, higher education, and now you've got years of experience and you can't do this, you wasted 7 years of your life learning things that you never learned how to apply, and that's why your patients are not going to get better. So watch. So with this patient, what we should be doing is A, asking them, did their Achilles pop when they were going down or when they were coming up? Because now that lets you know, was this an eccentric loading issue or was this a concentric exploding issue? Totally different muscles having issues causing the same problem. So two completely different scenarios. My bet is this was a pronation control issue because pronation is much harder to control because it's an eccentric loading. We all know that muscles have a harder time with eccentric loading than they do concentric unloading or exploding. So if I have this patient just do a squat, so just do a double-legged squat, Cole, and we're just gonna say that this is a right-sided issue. So if he does a squat and he shifts to his left because he can't dorsiflex, or he complains of Achilles tightness or pain when he gets down towards the bottom, we know that this is a loading issue. Come back up. Now, what typically physical therapists do, and most strength and conditioning coaches, and probably what Knees Over Toes would lead you to believe, is that this is a problem here with dorsiflexion because he has a tight Achilles or tight gastroc or tight soleus. He may have limited motion there, and he may complain of tightness in the plantar flexor complex, but that doesn't mean we go stretch that, roll that, and make it lengthen. What we need to find out is, why is this overworking so much? So when Cole is descending into his squat, go ahead and go down, we know that he is pronating at the hip, the knee, and the foot. What controls pronation at all of those? Come back up. Glute med, tensor fasciae lata, vastus lateralis, soleus, which is why he's getting tight with dorsiflexion. What else? Abductor hallucis should be kicking out to stabilize the arch so he can go down and collapse under control into pronation at the foot. So if those things are not working, you also have hip rotators because he's going into hip rotation. If the deep hip rotators don't work, then we have problems there. So I just gave you hip control, knee control, ankle control muscles that are a problem that my bet is you're skipping over when you're assessing these patients, which is why they're not getting any better. So if Cole's client, who's 67 now, tore his Achilles when he was 47, and they never figured out what was going on with all of that stuff, what do you think he's been doing for 20 years? He's been compensating for what caused his Achilles problem in the first place. Now, for the next 20 years, he's been compensating for the Achilles problem after it became a problem. So he's got all of these compensation problems that he shows up to see Cole, who wants to do knees over toes and personal training things, and now Cole's banging his head against the wall because he's fighting over 20 years of compensation. So what we should be doing is breaking this patient down, assessing gluteus medius, minimus, tensor fasciae lata, vastus lateralis, soleus, abductor hallucis, as they individually contract. If those muscles are inhibited or weak or lack muscle endurance, those are the things that need to be assessed and reversed before we can send them to somebody like Cole who wants to do personal training or knees over toes. Because once we get that stuff fixed, knees over toes is a fantastic program for him to go through with some tweaks. So if you want to know more about the tweaks that we have to add to knees over toes to make it a phenomenal program, keep watching for further videos.